This video will be describing closed reduction of developmental dislocation of the hip with the application of a waterproof cast. These are my co-authors. The indication for the procedure is developmental dislocation in an infant who has either failed orthotic treatment or is deemed too old to start orthotics. The equipment necessary for the procedure will be a casting table, waterproof underwrap, and fiberglass. General anesthesia is required, and our preference is to have cross-sectional imaging in the room. In developmental dislocation of the hip, the objective of treatment is to achieve a stable reduction to promote congruent, coupled motion between the proximal femur and the acetabulum. The first part of the procedure is to perform an exam under anesthesia while the baby is relaxed. By flexing and adducting both hips, a Galeazzi sign becomes apparent. The child's right knee sits lower than the left. Next, by placing the plantar surfaces of the baby's feet together, asymmetric abduction is obvious. By abducting and levering the femoral head into the joint with gentle pressure, we are reproducing the Ortolani maneuver, and a closed reduction is achieved. The hip is seen dislocating posteriorly with adduction. Once again, the closed reduction is demonstrated with gentle traction and abduction. At this point, the so-called safe zone should be evaluated and the hip should be stable with no greater than 45 degrees of abduction. If the safe zone is too small, an adductor tenotomy can be considered. On the contrary, if the safe zone is ample, then you can proceed with closed reduction and casting. This technique will show how to apply a waterproof immobilization device. First, a Gore-Tex liner is placed, which is beneficial for maintaining good hygiene. We use a spica table that is well padded. The baby is placed onto the spica table, which supports the shoulders and the sacrum while ensuring the chest is free for casting. 2 small towels should be placed on the abdomen to ensure room to allow for breathing and feeding in the cast. This procedure requires the collaboration of 3 people, 1 to hold, 1 to cast, and 1 to be able to evaluate all sides of the cast to ensure the skin is free. It is crucial to hold the foot without occupying too much space to avoid blocking the area for the person casting. In order to best do this, it is easiest to hold the foot with 2 fingers above the ankle and the thumb in the palm. This allows the holder to be completely free out of the space of the caster while maintaining the human position, which is 90 degrees of hip flexion. The holder should also be as close as possible to the baby, since the tendency will be to relax and extend the hips. They should also be in approximately 30 to 45 degrees of abduction according to that predetermined safe zone, and should be in neutral rotation. We will then begin to roll the waterproof cast padding, which is made of polyethylene. The first roll should be used for the abdomen only. Then a 2-inch roll should be used to go along the leg down to the level of the ankle, just proximal to the malleoli. Both legs will be included in the cast even if dealing with a unilateral dislocation. Once the waterproof cast padding has been applied to both extremities, ensure the person holding is comfortable and verify the position of the extremities. Once again, we begin at the torso, wrapping just below the level of the nipples, using a 3-inch roll. You can then fold the Gore-Tex liner to create a nice rounded edge. Keep the towels in until the end to ensure the extra room is maintained. The art of placing a hip spica is crossing the actual joint. One must verify the reduction again, then a 2-inch roll is begun at the level of the umbilicus. The cast material is passed over the hip joint while holding it with the index finger and then coming up and around the belly, as this truly creates a crisscross or a spike pattern. The third assistant can help to hold this corner down as it does tend to lift up. This part is the spica itself. This figure of 8 creates the fundamental struts of the cast, ensuring it holds its shape and therefore holds the hip reduced. One should be able to achieve at least 3 passes for each hip. The strength of the spica cast does not come from the thickness of the layers, but rather from the width between the groin and the gluteus. After the cast has been passed 3 times around the hip, one can continue down the extremity using another roll of 2-inch cast material. Once the cast has been applied to the level of the malleoli, it is very important from a technical standpoint to apply a trochanteric mold. This should be applied with the left hand for the right hip and the right hand for the left hip, with the surgeon standing at the patient's shoulder. Here you can observe how the left hand, with gentle pressure under the greater trochanter, is being produced while keeping the knee in 90 degrees of flexion. Care is taken to avoid digging into the popliteal space. A gentle pressure is applied and molded to hold the hip in this position of maximal stability. We typically begin with the affected or more unstable side. Only after the cast has been completed, the other side is casted in the same position using the same technique of going above the belly and below the thigh in successive turns, creating the spica struts. Some gentle molding can be done for symmetry, but pressure points should never be created. We then finalize the cast by folding the Gore-Tex liner at each edge and once again verifying the position with the foot pointing forward and the hips held in the so-called human position. It is important to ensure enough space for a diaper and hygiene. A final roll of fiberglass can then be taken and placed to hold the Gore-Tex in place and to strengthen the overall cast. Once the cast has hardened, the patient is taken off the spica table and placed on a regular radiolucent table. The use of cross-sectional imaging to evaluate the reduction is crucial and is done before waking the child. If a successful reduction is not observed, the cast is removed and the procedure is repeated. We prefer to use 3D intraoperative CT. In reality, only the cuts demonstrating the position of the proximal femoral epiphysis in relation to the triradiate cartilage are needed, since these are the most objective measure of quality in the reduction. In these images, adequate positioning is observed. The entire cast is overwrapped using a soft-colored wrap, which is beneficial for hygiene and comfort. The human position is maintained for 3 months with a cast change at 6 weeks. The objective is to achieve a stable reduction. However, acetabular dysplasia typically persists, and for this reason, continued casting is recommended until a significant improvement in acetabular development can be noted. Our post-operative protocol includes maintaining the position for 3 months, a cast change which can be done under general anesthesia if necessary, bracing and abduction after cast removal, and no physical therapy.